Assalamu alaikum. Good afternoon, everybody. And we would like to welcome Dr. Zuhair. He's with us now. Today, our activity it will be started with the multiple valve disease, as Dr. Zuhair is the guest for this lecture. Then after that, we'll continue with the tricuspid valve. Then redo with Dr. Ahmed. I'm Dr. Khalifa. I will be the panelist with Dr. Abdurrahman today, inshallah. We can start with the multiple valve, please. Go ahead, Muhammad.
Good afternoon, everyone. I'm not sure whether we should start now or give 4 minutes until the participants to give time for the other participant to join.
It's okay, no problem. If you'd like to wait for the more participants, it's okay. We'll wait, then at 1:05 we'll start. Okay, Dr. Muhammad, we can start, please.
So good afternoon, everyone. Thank you to each and every. Thank you to each and every one of you for being here with us today. We are very pleased to be able to have Professor Zuhair Al-Khalis, who kindly accept his guest invitation to our presentation today, multiple valve disease. Though single valve is our talk with presence of Dr. Zuhair, but this is an overview of multiple valve disease that we will go through introduction, natural history without treatment. If we have multiple valve disease with no timely fashioned intervention, what would happen? Pathophysiology, and in the pathophysiology, there are three systemic diseases that are commonly causing multiple valve disease that we will talk about them in brief. And then we will go to indications for operation, and that is quoting from American Heart Association and American College of Cardiology 2014 and 2020. The outcome of the multiple valve disease, and then we will discuss a case, or we will present a case of quadruple valve replacement. So all of those information that's been prepared and the presentation was based on STS database informations. As a cardiac surgery matures, cardiac surgeons are treating patients with more complex pathology than routine coronary artery bypass or single valve replacement. And this in this picture here that we can see in the normal heart, the valves have a characteristic orientation with supportive elements. I just wanted to enforce the idea of proximity of the valves each together in case of multiple valve disease, and how sometimes it's difficult to approach them. So the central fibrous body is the core of the heart skeleton, which unites the aortic, mitral, and tricuspid valves, and is made up by the right fibrous trigone and thick division between the left ventricular outflow tract, the right atrium, and the right ventricle. The right fibrous trigone is the strongest part of the heart's fibrous skeleton, as shown in the figure. The aortic, mitral, and tricuspid valves are straddled the heart's fibrous skeleton, with the aortic valve lying most central. The pulmonary artery is connected to the aortic valve by the conal septum, and the point here is when operating on any single valve, knowing its relationship to the remaining valve is important. But when operating on multiple valves, preserving or reconstructing the fibrous skeleton in addition to repairing or replacing the valves may be required sometimes. Furthermore, maintaining coronary circulation and avoiding the conduction system is also required to preserve the mechanics and function of the heart following reconstruction. Going to the American College of Cardiology and American Heart Association guidelines from 2014, and according to them, valvular heart disease diagnosis begins with a thorough patient history and physical exam, because the degree of symptomatology remains extremely important in the decision to intervene or not. Tests generally begin with, as we know, ECG, chest radiograph, a transthoracic echocardiography, and may also include transesophageal echocardiogram. CT also could be used, stress testing, cardiac cath, or cardiac MR. The standard initial diagnostic test according to these guidelines is currently a transthoracic echocardiogram, because it can evaluate all valves and determine atrial and ventricular function. The transesophageal echocardiography can better visualize complex anatomy and valvular irregularity. Patients with symptoms that are more severe than the transthoracic echo, transesophageal echo, should undergo cardiac cath to measure valve gradients, cardiac output, and coronary plaque burden. Given the natural history without treatment, multivalvular disease generally ends in heart failure, both left and or right. The effects of single valve dysfunction can directly cause an upstream valve to fail. So sometimes it began with a single valve, ends up with multiple valves. How that could happen, for example, when the aortic valve becomes stenotic. This picture only to imagine the pathway. For example, when the aortic valve becomes stenotic, the left ventricle becomes pressure or volume overloaded, and the mitral valve can become insufficient. Accordingly, the left ventricle begins to fail, and with worsening mitral regurgitation, the left atrium can become overloaded as well, leading to pulmonary edema. As with left-sided coronary disease, left-sided valvular heart failure progresses to right heart failure. Right ventricular failure, which causes increased right ventricular volume, leads to dilation in the tricuspid annulus and insufficiency. Both the culprit and the upstream valves often require intervention, and this is what we are going to discuss. Talking about the pathophysiology here, multiple valve disease is primarily a result of a systemic disease. Infection, rheumatism, and degeneration are the most common reasons multiple valves require surgical attention. Additionally to that, systemic disease such as hypertension can alter the anatomy of the heart, leading secondarily to multivalvular dysfunction. Talking about the incidence of infective endocarditis, has risen from 11 per 100,000 patient in 2000 to 15 per 100,000 in 2011. So there is an increase in all organisms also causing infective endocarditis, but the most common remains Staphylococcus, which causes 40% of the cases. This diagram here shows that out of 457,000 infective endocarditis related hospitalizations in the United States from 2000 to 2011, enumerating that the highest is the Staphylococcus aureus, followed by Streptococci species and gram-negative, and then the fungus. Endocarditis pathophysiology follows a directed pathway and usually started beginning with the damage to the endocardial surface. Then the damaged area attracts platelets and forms thrombi and mini thrombi, causing because of the bloodstream transitly circulates bacteria or other organisms, the thrombi become affected and continue to grow. And the patient then may become symptomatic and the vegetation may become visible. And this is the cascade of infective endocarditis. Talking about the rheumatic heart disease, still and remains the leading cause of multi-valve disease. And this picture was published in the Lancet 2016. We can see change in age, standardized prevalence and number of prevalent cases. So here, talking about Saudi Arabia, it is increasing, not decreasing, in number of the rheumatic heart disease, and that is alarming somehow. Though the number of increasing cases is not really high compared to other countries, but we're still lacking behind to cut off and prevent rheumatic heart disease from happening. And there is, for rheumatic heart disease, there is a slow fibrotic reaction that most often affect the mitral valve, leading to progressing thickening, leaflet retraction, and chordae shortening. And with time, the leaflets harden and develop calcifications. The combination of calcifications and restrictive movement cause the combination of mitral stenosis and mitral insufficiency. Although less commonly, the aortic and tricuspid valves can also be affected by the fibrosis after acute inflammation and rheumatic fever. The most common combination is aortic and mitral valve involvement. Speaking about the degenerative valve disease, usually occurs in patients older than 75 years. Related to aging, prevalence rises as life expectancy increases, and due to improvement on the healthcare delivery, we expect increase on that in life expectancy and late presentation of patients with degenerative valve disease. So the classic calcified aortic stenosis can be associated with mitral valve calcification in up to half of patients over 75 years. Degenerative mitral valve disease has a prevalence of 1.6% to 2.4% in recent studies that was published in the STS. Mitral valve prolapse, annular dilatation, billowing mitral leaflet, and chordal rupture characterize degenerative mitral valve disease. The concomitant tricuspid valve regurgitation can result from elevated left-sided pressures and right-sided ischemia. Also, the atrial fibrillation, pulmonary artery hypertension, and right ventricular dysfunction can all complicate tricuspid regurgitation to be added to the myth. Now, speaking about the indications for surgical intervention. So, for individual valves of the heart are the genesis of recommendations for multiple valve intervention. For example, if two valves are infected with endocarditis, each having vegetations and severe insufficiency, then clearly both valves need to be addressed individually, as both meet criteria for treatment. However, often a clear indication for intervention of one valve may be present, but a less clear indication for another exists. So because the surgical risk increases with more complex procedures, needlessly replacing or repairing another valve can be counterproductive. So the guidelines are made of primarily of singular valve, but there are some recommendations in regards to the mitral and tricuspid valves. Common sense and individualization dictates that procedures that can improve left, right, or biventricular failure are warranted, because the chest is often open and cardiopulmonary bypass is underway. An opportunity exists to treat valvular disease that may not meet criteria as a sole intervention, but is known to progressively deteriorate. An example here, a severely stenotic aortic valve with ventricular dysfunction and moderate mitral regurgitation provides clear indication for replacing of the aortic valve, but the patient may also benefit from having the mitral valve treated as well. So concomitant valve surgery with moderate disease is often prudent, provided the perceived future benefits to the patient outweigh the current risks. In addition to that, hemodynamic flow characteristics across one valve may influence the evaluation of another. Example here, in patients with aortic stenosis, mitral stenosis can be challenging to assess because the flow across the mitral valve will also be diminished, as well the gradients of the mitral valve. Thus, the typical parameters to assess the mitral stenosis may be unreliable. Those are all obstacles to give a clear indication for the multiple valve disease through the guidelines. Here we can see that in 2017, American Heart Association and American College of Cardiology guidelines that the concomitant mitral valve repair or replacement is indicated in patients with chronic severe primary mitral regurgitation undergoing cardiac surgery for other indications. Class 1 level of evidence B. Another recommendation that concomitant mitral valve repair is reasonable in patients with chronic moderate primary mitral regurgitation when undergoing cardiac surgery for other indications, and this is class 2A level of evidence B. The third recommendation in regards to mitral valve surgery is reasonable for patients with chronic severe secondary mitral regurgitation who are undergoing coronary artery bypass grafting or aortic valve replacement, and the class 2A level of evidence C. So clearly we can see that concomitant mitral valve surgery indications, unless it is chronic severe primary, is a gray zone where expertise and patient flow can and the patient benefit risk ratio can dictate whether the patient should go for aortomitral or only like mitral or just omit the mitral surgery or repair it or replacing that. But of course, at the end, we will allow Professor Zuhair Haris to put his input, as here in Saudi, I believe we have more valvular heart disease and surgeries than in US or in Europe. In regards to the tricuspid valve and the 2017 guideline, They first point that tricuspid valve surgery is recommended for patients with severe tricuspid regurgitation undergoing left-sided valve operation, class 1, level C. The second point, tricuspid valve surgery is recommended for patients with severe tricuspid stenosis at the time of operation for left-sided valve disease, class 1 level of evidence C. Last but not least, the tricuspid valve repair can be beneficial for patients with mild, moderate, or greater functional tricuspid regurgitation at the time of left-sided valve operations with either tricuspid annular dilation or prior evidence of right-sided heart failure, class 2A level of evidence B. Tricuspid valve repair may be considered for patients with moderate functional tricuspid regurgitation and pulmonary artery hypertension at the time of left-sided valve surgery, a class 2B level of evidence C. And as we again can see that even the guideline cannot tell when exactly to intervene in a multiple valve surgery. This is a piece of information that, and lastly, if the aortomitral curtain is not structurally adequate to accept sutures for replacement or repair of both the aortic and mitral valves, whenever indicated, then reconstruction of the aortomitral curtain is required in addition to the valves. And this is just telling how difficult and severe is the issue of involvement of more than single valve surgery. In summary, here I want to summarize whatever the indications. The indications for multiple valve disease rely on the individual function of each valve and the pathophysiology of this function. Second, the risk of the operation is more than additive with each additional valve that needs repair or replacement. And again, national guidelines by American Heart Association and American College of Cardiology for treatment of multiple valve pathology are still limited. The type of valve decision, speaking of that, regarding the type of valve replacement, the 2020 American Heart Association and College of Cardiology guidelines have significant changes because of the latest research in the transcatheter valve replacements. So the obvious and yet still most significant take-home point is the need for well-informed patients and the shared decision-making process to involve patients in their decisions. So of note, I just quoted this statement from the American Heart Association, American College of Cardiology guidelines, maintain that valve and valve options, while possible, are not yet proven, stating the use of a transcatheter valve and valve procedure may be considered for decision-making on the type of valve, but long-term follow-up is not yet available. And some bioprosthetic valves, particularly the smaller sized valves, will not be suitable for a valve and valve replacement. Both mechanical and bioprosthetic valves have indications and advantages considering the longevity of the valves and known risks of thrombosis and the need for anticoagulation. This is in regards of the decision of the valves. So coming to the outcome of the multiple valvular disease operations. It is difficult to study given that the cause of the secondary valve operation is not always captured in the overall operative diagnosis. Therefore, global statements regarding multivalvular disease outcomes are difficult and still limited. The Society of Thoracic Surgeons data is the most comprehensive, which was presented at the American Association of Thoracic Surgeons meeting in 2010. In changing outcome characteristics of multiple valve surgery in North America, data from the STS from 1994 throughout 2007 found that today's patients are more likely to have renal failure of 8%, severe lung disease of 22%, and cerebrovascular disease of 15%. Although concomitant coronary disease is becoming more prevalent overall, patients with multiple valve disease had less coronary disease than patients with single valve disease. Regardless of the combination of valves, patients with multiple valve disease had unadjusted mortality rate that were twice as high as for patients with single valve disease. So any additive valve is an additive overall risk to the procedure. Just a piece of information that between 2003 and 2007, the unadjusted operative mortality for aortic and mitral valve replacement was somewhere around 10%. And for the aortic and tricuspid valve replacements were around 11% and 8% for mitral and tricuspid valve replacements. And for all three valves, the mortality can reach up to 13%. And that is what's shown in the STS data. Here I can finish the overview of the STS database about the multiple valve diseases. And I would allow Professor Zuhair Al-Halis, if you don't mind, to give us some insight or your expertise over the years about the multiple valve diseases.
Assalamu alaikum.
Assalamu wa rahmatullah.
Thank you, Mohammed, for that presentation. It was, if I would say that each of the points that you have mentioned on many of the valves is by itself maybe an indication for a conference. And as you know, there are conferences that are dedicated to mitral valve alone, others to aortic valve alone, and etc. And you kind of gave us a comprehensive look at the 4 valves. Nevertheless, there are a few points that I would just to emphasize in terms of the pathology. First, that most of the pathology that we used to see here, particularly in reference to the aortic and mitral valves, was rheumatic heart disease. And there is no doubt that if I look at the time that I started here and the time now, we are seeing less and less of rheumatic heart disease, particularly in the acute form, in the acute presentation, which is a plus for you. And we are seeing now only the burnout rheumatic heart disease, with the mitral valve probably more than the aortic valve, as you all know. In terms of dealing with the rheumatic valve disease, the possibility of repair is of course there, but the outcome or the long-term results have been consistently for mitral valve repair in rheumatics and the aortic valve repair in rheumatics is not as good as for in other indications. But nevertheless, because of most of the patients present early in life, we always try and repair first. Not because of the age of the patient, but also because of the fact that we know that in general, the long-term outcome of repairs is better than a replacement. And we all know that the replacement of the valve is associated with so many problems that can really change the life of the patient. The other pathologies that were referred to are the degenerative and the functional. I think for the aortic valve, we don't see functional etiology. We see it for both mitral, mostly in ischemic mitral valve disease, and also for tricuspid, for any kind of disease, particularly if there is pulmonary hypertension, that can generally lead to annular dilatation of the tricuspid valve and regurgitation. In terms of the management, as I mentioned, the valve repair is generally better, but then it comes to if a repair is not feasible, then you have to replace the valve. And then replacing the valve becomes, in general, a dilemma in itself. We have many, many options that are available for the replacement. But briefly, we can refer to them as being mechanical option and biological option. The mechanical option at the present time that is available is probably only the bileaflet mechanical valve, with all of the companies are using that same system. However, the companies differ in terms of the effective orifice area of the valve and the type of the of the sewing ring that the valve has. And because of that, and of course the hinge mechanism, and because of that, you will see difference in different. You probably cannot say that a St. Jude, for instance, 21 is the same mitral valve orifice area as a 21 carbomedics. This is unfortunate because it's not really standardized till now, and any attempt to standardize that is really fought by the companies, because you force them to do something that they probably against their marketing strategies. The hinge mechanism if differs from valve to valve, and that's why they're telling you that some valves require less anticoagulation than the others. However, at the present time, the evidence is that all mechanical valves will require anticoagulation with Coumadin. Currently, there is a study in the United States, multi-institutional study is ongoing, using the Onyx valve with apixaban, one of the new coags, one of the new oral anticoagulants, and this is ongoing, but they are, whenever an Onyx valve in aortic position is implanted, is randomized to warfarin versus apixaban. This is early. I think it's only 2 or 3 years since the study started. Until now, we don't have any result from that study. There was a study that was carried out in Italy before, where actually randomized Onyx valve, again aspirin only, to aspirin with low INR to warfarin with recommended INR, and in the aspirin low INR arm there was more thrombosis. So that trial, I think, was discontinued, and since then the only new trial is the currently ongoing with the apixaban versus the warfarin now. The biological valves, we have the standard distented and the stentless, and of course you have the homografts and the homografts, aortic and pulmonary. Of course, the pulmonary valve as a homograft did not do well in the aortic position as a homograft per se, which is very interesting and shows that whenever you use the patient's own pulmonary valve, that is the ROS, the pulmonary valve works well, which means that the pulmonary valve in this case is alive, not like when you use it as a homograft. The stentless have the advantage of having lower gradients in smaller sizes. The disadvantage of the stented valves is when there is a small annulus, you almost invariably end up with a gradient, particularly during exercise. I don't know if there are any other points that you want me to mention, but I believe these are very important points that one has to keep in mind as take-home messages.
Fair and well, Dr. Zuhair, thank you. I believe we will continue with 3 or 4 remaining slides, and then we will allow for questions that the audience and participants can take advantage of your presence here today. Quadruple valve replacement. Speaking about the difficulty of multiple valve disease and how difficult is the decision and involving the patient, their decision and the choice of the valves and the outcomes of each of them. The question comes up, is it feasible to proceed and change all 4 valves of the heart? I'm gonna present one case here that has been done by Professor Zuhair Al-Halis, and his experience always is shining. Here we have a 24-year-old young man who is known to have recurrent culture negative infective endocarditis, hypereosinophilic Wells syndrome, which is kind of allergy syndrome, recurrent splenic abscess, status post splenectomy, and multiple valve disease predominating regurgitation. The patient was not diabetic, had no previous myocardial infarction, no previous cerebrovascular accident, no impaired renal function, no peripheral vascular disease, not hypertensive, not a smoker. The ejection fraction was 55%, and of course, giving this ejection fraction with all 4 valves regurgitant, and that would raise a question whether this ejection fraction is a real reflection of the heart functionality. With the quadruple valve regurgitation, status post triple valve repair in Belgium in 2017, and the case was done on 2019. So the patient was presented with dyspnea on exertion, class 3, New York Association, and exercise intolerance on and off palpitation with lower limbs edema. Echo at the time of admission showed severe aortic regurgitation, pulmonary regurgitation, and mild mixed mitral regurg with stenosis, moderate tricuspid regurgitation with moderate pulmonary hypertension. Patient was deemed by the King Faisal Heart Center meeting to be operable under care of Professor Zuhair Al-Halis, and they planned for surgical valve replacement of aorta, mitral, and tricuspid valve with right ventricle to pulmonary artery graft. So this is a summary of the outcome of this patient. His age was 24. He is a male with a class 3 NYHA, his height and 158 with weight of 62. His body surface area was 1.65. He had allergies to clindamycin, Bactrim, bovidone, Tigadem dressing, and that was an additive risk to his wound healing, plus his Wells syndrome, and intravenous contrast allergic. His post-operative NYHA class was 1, and this shows a great improvement of his functional status. The SS score was 4 at the time of procedure. The cross-clamp time was 119 minutes, replacing all 4 valves. The bypass total time was 222 minutes. The aortic regurgitation was severe, and the valve implanted was 23 millimeter carbomedics reduced annulus. Mitral regurgitation was severe, and the valve implanted was 29 millimeter carbomedics bileaflet. Tricuspid regurgitation was severe, with valve implanted 31 millimeter subdued epic porci. Pulmonary regurgitation was also severe with moderate pulmonary hypertension, and the valve implanted was RV2PA 23 millimeter cryopreserved pulmonary homograft. The Euro score was 5, falling on moderate risk. Estimated blood loss was 1 liter. The left ventricle was showing good ejection fraction of 55% with dilation of the left ventricle. The right ventricle was moderately dysfunctional with dilation. ICU stay of this patient post-operatively was only 2 days, and the patient was discharged home. The readmission of 30 days, there was no readmission, and the patient, last time I saw this patient after discharge by 18 months, with excellent functional status, came for only cardiology follow-up to do his echo and further management. Here is the, I just wanna have your input, Professor, in regards to quadruple valve cases. I had a review the guidelines, and the guidelines stopped at the level of triple valve, and their only recommendation is Repair is better than replacement with no further elaboration on that. If you could, if we can have your opinion in this regard.
Well, as I know, having the 4 valves involved in disease process is very, very rare, and that's why I don't think nothing is mentioned on the guidelines. However, and actually, even in our experience, very few patients have ended up having the 4 valves involved. However, the other thing is, of course, the indications, to deal with the pulmonary valve are in general very limited and mostly are due to congenital. However, when we started doing also the Ross procedure for patients with rheumatic heart disease, some of these patients initially start with the aortic valve, and then you deal with the aortic valve, and then the process goes on, and then they present again with mitral valve disease, and then the homograft in the pulmonary position becomes diseased, and then they develop maybe pulmonary hypertension, and the tricuspid valve becomes diseased. So you end up with a patient with 4 valve disease. And actually, I must say that this was one of the criticism or the arguments against the routine use of the Ross procedure, is many surgeons good surgeons, authorities in the field would tell you that you're converting a 1 valve disease to a 2 valve disease, and that 2 valve disease may end up with even more than that. However, we know that our usage of our utilization of the procedure in patients with rheumatic heart disease has become in a way limited, because we know that patients with rheumatic aortic valve disease and dilated aortic annulus and aortic valve regurgitation are probably not good candidates for the Ross procedure. As you know, rheumatic heart disease rarely affects the pulmonary valve. I think, if I remember, we have maybe 3 cases, not more than that, and actually one of them we reported as a case report where we had the rheumatic process in the 4 valves, involving the 4 valves in the same patient. I guess that's the reason why you don't see it in the guidelines. However, the outcome really depends on the ventricular function. If the ventricular function is preserved, the outcome of even replacing the 4 valves is expected to be good.
I see. So, Professor, is giving the background of 4 valve disease and mentioning ejection fraction of 55%, is that reliable ejection fraction, or it is only an estimation of current ventricular function?
Well, as you know, patients with valvular regurgitation are the ones that you may overestimate the ventricular function, because usually the left ventricle is overloaded, and had to compensate for that by increasing the ejection fraction. So when you get rid of that regurgitant fraction, the LV function becomes depressed. It's a little bit different in stenotic valves. So you have to take everything into context, and I think the echocardiographers are aware of that. And actually, when they report a ventricular function in a patient, say, with severe aortic valve regurgitation, they would bring to your attention that this is in the context of aortic valve regurgitation. So when you operate on the patient, you expect that the ejection fraction will probably drop a little bit.
Thank you for your input, Professor. I believe...
Excuse me, Muhammad?
Yes, please.
Yeah, once Dr. Zuhair is here, we have a question. How about pre-op for those patients? Because as Muhammad mentioned, most of those patients present with a heart failure before. So how you get improved in pre-op?
Well, that's where your cardiology colleagues come into action. If the patient is in heart failure and there is, no emergency situation, though the patient has to be admitted to the hospital, treated for the heart failure. And I'm sure all of you know there are many medications that can be utilized in that setting, in addition to the diuretics. And then the whole situation after control of the heart failure can be reassessed and discussed. Occasionally you may not have the luxury of doing that, and then you just have to do to go ahead with the procedure with optimal backup, and then hope for the best. Invariably, the patients, after taking care of the causative lesion, invariably the patients get better and their heart failure either completely resolves or can be easier controlled.
Thank you, Doctor.
So I would like to thank everyone. Thank you so much, Professor, for your presence. I would like open for questions. If there is any question or comments from the audience and participants, please go ahead.
Thank you, Professor Alis, for your time. We really appreciate your presence and time and comments. Thank you, Mohammed, for the presentation, concise and comprehensive as usual. Dr. Alis, just regarding the choice of the biological valve, let's say, like, I understand that's mostly, many of the times, depends on the availability of type of valve or biological in the center, but out of all the biological valves available in the market, which one you would prefer? And is there a single type of valve, biological, that you're choosing for all patients, or it depends on the patient? Any input on that?
Unfortunately, it's very, very difficult to answer that question. But I mean, sometimes the valve gets introduced into the market with very short kind of follow-up, and mostly in animal studies that they are extrapolated into humans. And many of them we have seen that have been introduced into the market and used, and then with clinical use they fail miserably. Examples of that historically is the Ionescu-Shiley bovine pericardial valve, that really, when it was introduced, was the kind of valve of the future. But unfortunately, it failed, and people, of course, stopped using it, and then it was withdrawn from the market. Basically, what we have now are the two major entities, the porcine valves, and the other ones are the bovine pericardial valves. One company at one time, which was called the 3F valve, that actually one model of it was made for sutureless implantation, was made of equine pericardium, but that was, of course, making it very expensive and did not seem to make much difference. So they stopped making it from equine and used bovine again. So you have the difference between the outcome in these different companies is the way they treat the valve for anti-calcification. Because, as you know, the major process of degeneration is calcification in the valve. So each company have a different methodology of decalcification, and some of them, keep it as a secret. At one time, there was one company that came up with a formula that they call it no-react. And they tried to convince us that there is absolutely no calcification in the animal studies. But then, the company was called Chile High. But when the valves were introduced into human use, the calcification was a major problem. The latest advance, I'm sure you have heard about, is from Edwards, where they actually have developed a new anti-calcification therapy, and they called that bovine pericardium the Resilia pericardium. And according to them, it's almost zero calcification in the animal studies. They made out of that both mitral and aortic models. The aortic model was introduced into clinical use before the mitral model. That's called the Inspiris valve. And to convince us that it is good for young people, they also made the annulus of the valve a little bit expandable. There was a mechanism in the stented annulus, so it can expand for future valve-in-valve in those patients when the valve fails. So this is a very difficult and tedious process. It's every once in a while we see something new has been introduced, and then the companies try to convince us to use, and then the clinical usage shows something different. On average, till now, I don't think that there has been a great advance in the number of years of degenerating bioprosthesis. But of course, we know that the younger the patient, the faster the degeneration. Most of, if you look at the guidelines, they probably would look at 65 or 60 years as the cutoff between young and old, where in general, they would recommend mechanical versus biological. However, because of the lifestyle and the people weary about using the warfarin, people have been using the bioprosthesis in younger patients outside the guidelines, as we do in here, because of the females with childbearing age and or patients' lifestyle that they don't want to use warfarin, or because of drug compliance, or because of unavailability of warfarin in some areas. Of course, when the valve-in-valve was mentioned, that kind of created a little bit less apprehension about using the bioprosthesis in the young. But as you know, the valve-in-valve is not the panacea for the problem. It in its own also has many many potential problems as well. But as I mentioned, in the average, if you want to look at the old and the young, many of these valves would start degenerating around 8 years and beyond. There are some certain factors in some patients that, anecdotes, like we have seen some young patients with the same valve for more than 20 years. But this is rather unusual. So I would say if you implant a bioprosthesis in any of the patients at the present time, you should probably follow those patients at least once every 2 years and keep an eye on them. Maybe when they get into the 8-year mark, you start, seeing them maybe yearly to make sure that they don't develop the degeneration.
I see. Thank you, Dr. Very comprehensive answer. Thank you.
Any other question or comment from the participant or the audience? I believe there is no more question. Thank you again, Professor, for your presence and your valuable input in this regard of multiple valve disease. Thanks for the audience for their patient hearing. Khalifa, if you would like to take over for the second lecture.
Yeah, sure. We would like to thank Dr. Zuhair for his supervising this session, and we'd like to thank all the attendees here. We will take a break. Thank you, Doctor. And we'll take a break till 2 p.m. Then we will start with the tricuspid valve with Dr. Zahra. Thank you, everybody. Assalamu alaikum. Welcome back. Dr. Zahra, are you ready?
Yes.
Can you share screen, please? And do you have any supervisor with you
No.
in this session?
No.
Okay.
Should I start?
Yes, please.
Assalamu alaikum. Good afternoon, everyone. My name is Zahra Idris. I'm a R5 cardiac surgery resident from King Faisal Specialist Hospital in Jeddah. My topic today is tricuspid valve surgery. I know last week my colleague Dr. Riyad presented the part about pathophysiology and anatomy of the tricuspid valve, so I'm not going to go into details about those, but we'll just mention some brief points about functional TR, as it is the most commonly encountered lesion when it comes to the tricuspid valve. So first of all, the tricuspid annulus is a component of both the tricuspid valve and the RV myocardium. And so for TR to occur, the annulus and the RV both must be dilated. And the dilation usually occurs in the anterior and posterior directions that correspond to the free wall of the RV. So to manage functional TR, the classical teaching has been for minimal right atrial enlargement and a TR that is +1 or +2, TR will resolve once we address the left-sided valve lesions. However, treatment of the mitral lesion alone will only reduce the RV afterload, but it will not correct the tricuspid annular dilation or the RV preload and function. And once the tricuspid annulus dilates, the size cannot return to normal spontaneously, and it will continue to dilate further, necessitating a second surgery if it were not addressed in the first surgery while repairing the left side lesion. So the primary mechanism for functional TR is tricuspid annular dilatation. However, for TR to occur, there are also other factors, including the preload, the afterload, and the RV function. And thus, the tricuspid annular dilatation can be measured objectively, whereas the tricuspid regurgitation cannot, because it depends on these factors. So significant TR may not be detected by echo, despite the annulus being considerably dilated. This is a paper that addresses these points and what the criteria should be for surgical repair of the tricuspid valve. In this paper, the authors postulated that the annular size may be a more reliable indicator of late outcomes than the degree of TR. And so they included 311 patients and who were undergoing mitral valve repair. In the first group, which included 163 patients, those were the patients who received mitral valve repair alone without addressing the tricuspid. And in the second group, they included 148 patients who underwent mitral valve repair plus tricuspid annuloplasty. In terms of results, what they found was not a huge difference in hospital mortality or the survival rates, but the NIHA functional class was significantly improved in group 2, who underwent the annuloplasty. And also they found that the TR increased by more than 2 grades in 48% of the patients in group 1 and only in 2% of the patients in group 2, with a significant p-value of less than 0.001. So they concluded that remodeling annuloplasty of the tricuspid valve based on tricuspid dilation improves functional status irrespective of the grade of regurgitation, and that considerable tricuspid dilatation can be present even in the absence of substantial TR. Tricuspid dilatation is an ongoing disease process that will, with time, lead to severe TR. So moving on to the 2020 guidelines, they state the stages of TR as follows. The first stage B, which is progressive TR, has the following hemodynamics: a central jet that's less than 50% of the RA, the vena contracta less than 0.7 centimeters, the effective regurgitant orifice less than 0.40 centimeters squared, and the regurgitant volume less than 45, and of course, no hemodynamic consequences or symptoms. And then stages C and D both have the same hemodynamics of a central jet that is 50 or more, vena contracta 0.7 or more, effective regurgitant orifice that is 0.4 or more, and regurgitant volume that is 45 mils or more, along with a dense continuous wave signal with triangular shape, hepatic vein systolic flow reversal. Stage C is asymptomatic, although there are some hemodynamic consequences like dilated RV and RA and an elevated venous pressure on presentation, whereas stage D has all the same manifestations and consequences, along with symptoms of heart failure, including dyspnea on exertion, fatigue, ascites, and edema. So according to the guidelines, the diagnosis of TR, class 1 is in patients with TR, transthoracic echocardiography is indicated to evaluate the presence and severity of TR, determine the etiology, measure the sizes of the right-sided chambers and IVC, assess RV systolic function, estimate the pulmonary artery systolic pressure, as well as characterize any associated left-sided heart disease. Whereas class 2A, in patients with TR, invasive measurement of the cardiac index, right-sided diastolic pressure, pulmonary artery pressures, and pulmonary vascular resistance, as well as right ventriculography, can be useful when clinical and non-invasive data are discordant or inadequate. So for the diagnosis, the transthoracic echo can distinguish primary TR with abnormal leaflets from secondary TR, which has normal leaflets, and also define the left-sided lesions and estimate the pulmonary artery pressure. In patients who have TR and undergone left-sided surgery, an annular diastolic diameter of more than 40 millimeters or more than 21 millimeters per square meters, there is increased risk of persistent progressive TR after isolated mitral valve surgery. So if the TR was not addressed during the mitral valve surgery. The pulmonary artery systolic pressure is estimated from the maximal TR velocity, and normal RV systolic function is defined by a TAPSE that is more than 16 millimeters, tricuspid valve systolic annular velocity that is more than 10, the RV end systolic area less than 20, or a fractional area change that is more than 35%. Other modalities such as 3D, transesophageal echo, MRI, CT scan can provide more accurate information on the status of the RV if needed. And in case of a weak TR signal or severe TR, there might be estimation of the pulmonary artery systolic pressure. In this case, a direct invasive measurement might be needed. All right, moving on to the timing of intervention. These are the latest guidelines in the 2020 American Heart Association guidelines. We'll talk about each individual one in the next slides. So first of all, the first recommendation, in patients with severe TR, stages C and D, undergoing left-sided valve surgery, tricuspid valve surgery is recommended. This is class 1, level of evidence B. Severe TR, as we said, should be addressed as part of the index procedure because it may not improve predictably after the addressing the left-sided lesion. And also because reoperation for severe isolated TR after left-sided valve surgery is associated with a perioperative mortality rate of 10 to 25%. Tricuspid repair is preferable to replacement. However, replacement may be necessary if there is marked dilation of the annulus or intrinsic disease of the leaflets or destruction, as with endocarditis. In the presence of severe RV systolic dysfunction or irreversible pulmonary hypertension, the risks and benefits of tricuspid valve operation should be carefully considered due to possibility of RV failure post-op. Okay, the second recommendation, in patients with progressive TR, stage B, undergoing left-sided valve surgery, tricuspid valve surgery can be beneficial in the context of either one, tricuspid annular dilation, so tricuspid annulus and diastolic diameter more than 4 centimeters, or two, prior signs and symptoms of right-sided heart failure. This is class 2A-B. For mild or moderate secondary TR, it may progress over time in about 25% of patients and can result in reduced long-term functional outcome and survival if left untreated. The risk factors for persistence or progression of TR include a tricuspid annular dilation of more than 40 millimeters diameter on pre-op echo at end diastole, or more than 70 millimeters diameter on direct intra-op measurement of the intercommissural distance. Other risk factors include degree of RV dysfunction or remodeling, leaflet tethering, pulmonary artery hypertension, AFib, and intraannular RV pacemaker or ICD lead. There have been some observational studies and one randomized controlled trial that demonstrated the benefit of tricuspid repair at the time of mitral surgery for progressive TR stage B in patients who have tricuspid annular dilation on echo. But the outcomes and as survival and the major adverse events are unfortunately lacking. All right, number 3, in patients with signs and symptoms of right-sided heart failure and severe primary TR, stage D, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalizations. This is class 2A-B. So this can be done in patients with severe congestive hepatopathy. They might benefit from surgery to prevent irreversible cirrhosis of the liver. If it were to be done, it should be preferably done before the onset of significant RV dysfunction or end organ damage. And again, the evidence is lacking regarding benefit and durability of surgery in this case with the current techniques. Recommendation number 4, in patients with signs and symptoms of right-sided heart failure and severe isolated secondary TR, which is attributable to annular dilation, in the absence of pulmonary hypertension or left-sided disease, who are poorly responsive to medical therapy, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalization. This is class 2A level B. So tricuspid regurgitation can develop in association with atrial fibrillation and annular dilatation. This is a form of secondary TR. It does have a different pathophysiology from the other forms of secondary TR with greater basal dilation and annular enlargement. Atrial fibrillation-related tricuspid regurg has rapid progression of TR severity and right-sided chamber dilation as compared to that with pulmonary hypertension or myocardial causes like dilated cardiomyopathy. And the outcomes are, again, better in those who don't have severe RV dysfunction or end organ damage. Recommendation number 5, in asymptomatic patients with severe primary TR, which is stage C, so asymptomatic, and progressive RV dilation or systolic dysfunction, isolated tricuspid valve surgery may be considered. This is class 2B level C. Corrective surgery can be considered in selected patients with severe primary TR when there is a pattern of continued deterioration on serial assessments of the RV size and function, and if the surgical risk in those patients is deemed acceptable. The final recommendation in patients with signs and symptoms of right-sided heart failure and severe TR stage D, so symptomatic, who have undergone previous left-sided valve surgery reoperation with isolated tricuspid valve surgery may be considered in the absence of severe pulmonary hypertension or severe RV systolic dysfunction. This is class 2B, level B. So the high reoperative mortality rate is due to the advanced nature of RV failure at the time of the second procedure, the residual pulmonary hypertension, LV dysfunction, and also presence of other valve abnormalities. However, if there is no significant pulmonary hypertension or severe RV systolic dysfunction, operation for severe symptomatic isolated TR years after the first surgery for the left-sided lesion may improve symptoms of right-sided heart failure. All right, so moving on to the surgical part. So tricuspid surgery setup, simply median sternotomy, cardiopulmonary bypass with 2 venous cannulae and tourniquets secured around them. The aorta cross-clamped and cardioplegia perfused into the aortic root. The incision is made in the right atrium parallel to the atrioventricular groove, and the exposure is achieved by anterior and posterior traction stitches on the edge of the atriotomy. So there are several techniques to address tricuspid regurgitation. The first one is bicuspidization. This is basically a technique to plicate the annulus along the posterior leaflet. That's because the posterior annulus is the only structurally unsupported area of the tricuspid valve annulus, so it is susceptible to dilation and subsequent TR. The technique is by placing pleated mattress sutures from the center of the posterior leaflet all the way to the posteroseptal commissure. And then a second suture is placed in the same way to further reduce the annulus. And the suture is then passed through a second pledget before being tied down. And finally, an annuloplasty ring can be inserted to further support the annular reduction. The second technique is the Vega Annuloplasty. In this technique, 2-O-proline or Gore-Tex suture is placed at the junction of the annulus and the RV free wall, and running from the anteroseptal commissure all the way to the posteroseptal commissure. And then the second limb of the suture is run parallel to and close to the first suture, and then again passed through a second pledget at the end. And once the suture is tightened, it will cause a purse string effect and reduce the length of the anterior and posterior annulus, that's providing adequate coaptation. The way to ensure the degree of annular reduction with the De Vega technique is either by inserting 2 and 1.5 to 3 finger breadths should fit snugly through the valve orifice and then tying, or by using the ring annuloplasty sizers, which are used for the rings that we'll talk about in the next slide. The annuloplasty sizer can be used as a template on the valve, and then the sutures can be tied to achieve the proper degree of reduction. The De Vega technique should be reserved for mild annular reductions. The third technique is ring annuloplasty. This one is used with significant degrees of TR and significant degrees of annular dilation to achieve more durable annular reduction. And we have rigid rings, flexible rings, and also flexible bands. The sizer of the ring is used to measure the intertrigonal distance, which is the length of the base of the septal leaflet of the tricuspid valve. And once the size is determined, the interrupted pledgeted 2O ethibond sutures are then placed in the same way from the anteroseptal commissure all the way to the posteroseptal commissure in a clockwise fashion, and then they're passed through the ring, and then the ring is brought down and the sutures tied. As you can see in the picture, there is an area that is open in the ring, so it's not a complete ring, and this is to spare the area of the conduction from any suture placement. All right, tricuspid valve replacement. Valve replacement should be performed in cases of persistent insufficiency or a valve morphology that is not suitable for repair at the time of initial inspection, like endocarditis, for example, or a destructed, severely rheumatic valve. Predictors for the need for valve replacement include jugular venous distension, increased severity of tricuspid valve incompetence, previous cardiac surgery, and the presence of tricuspid stenosis. So prosthetic valve choice, as with mitral valve replacement or aortic replacement, the same considerations apply: patient's age, anticoagulation considerations, childbearing wishes, as well as social issues. However, compared to the mitral position, bioprosthetic valves in the tricuspid position exhibit longer durability with a longer duration of freedom from structural valve dysfunction. The poor results that were that used to be seen with mechanical valves due to thrombosis, mostly with older models like the tilt-in disc or ball and cage. However, the newer designs have promising results. A 2001 report of bioprosthetic tricuspid valves reported freedom from structural deterioration was 96% and non-structural dysfunction was 77%. In series that compare bioprosthetic and mechanical valves, they have shown equality during follow-up between the two types. And the development of thrombus on mechanical valves can be treated nowadays successfully with thrombolysis. There is no survival benefit in the bioprosthesis over the mechanical valve in the tricuspid position, according to a recent review and a meta-analysis. However, the bioprosthetic valves have the mainstay of safety, of not developing thrombosis or requiring anticoagulation. And since the advent of percutaneous valve-in-valve treatments for structural deterioration, bioprosthesis are being considered more and more in younger patients. However, it has to be a bigger size to accommodate a valve in the future. All right, so for mechanical valves, one technique for implantation is to preserve the tricuspid valve leaflets as is the case with the mitral valve, to preserve the subvalvular structures and to avoid injury to the conduction system. However, there's concern about the anterior leaflet billowing and causing obstruction. So the central portion of the anterior leaflet can be excised and still preserve the chordal attachments. And then everting suture technique can be used for implantation of the mechanical valve in the tricuspid position. Another technique is by excising the entire native valve and leaving a small part of the septal leaflet to assist with the valve implantation. Then one mattress pledgeted suture is run through the sewing ring of the valve and then through the middle of the remnant of the septal leaflet, and securing the valve in this position. And then the remainder of the valve would be secured with continuous stitches from sewing through the septal leaflet on either side, clockwise and then anti-clockwise. And to prevent injury to the bundle and the conduction system, the stitches should stay as shallow as possible and only in the leaflet tissue. Here shows the alternative technique, which is through the usual interrupted pleated sutures. Here showing us the way of implanting a bioprosthetic valve. Similar technique. I think it can be done in the similar interrupted pleated suture techniques, but in this textbook source, they had this picture where part of it was done in the continuous technique, and then the area of the conduction, they used interrupted sutures. The last option is using a mitral homograft in case, usually this is used in case of endocarditis with a severely destructed native tricuspid valve. So for the homograft, the way it's prepared is by removing all the myocardium that is attached around the annulus of the valve, leaving only the annulus and the tissue and the leaflet, and also by shortening the papillary muscles to leave about 10 millimeters of muscles below the chordal attachment. And then obviously the native valve is completely excised and debridement of any infected tissue is done. And usually the anterior papillary muscle of the native tricuspid valve is the only one suitable for attachment of the papillary muscle from the homograft. And then the leaflets of the from the homografts are positioned and oriented so that the anterior leaflet of the mitral homograft is to the ventricular septum, basically at the site of the septal leaflet of the native tricuspid valve. Following that, and this will be secured with continuous sutures. And following that, the anterior papillary muscle of the homograft is attached side by side to the anterior papillary muscle of the native tricuspid valve. As for the posterior papillary muscle of the homograft, a small channel is created on the RV free wall, and then the posterior muscle is attached to the epicardium. And finally, the implantation is completed with an annuloplasty ring to further reinforce the tricuspid annulus. So outcomes of tricuspid surgery. In a study by Kim et al., operative mortality was 10% for isolated severe TR. Factors associated with a poorer prognosis was pre-op anemia and a larger RV and systolic area. In another study by Park et al. In tricuspid surgery after left-sided valve surgery, the outcomes were improved with no hospital mortality, and the 1, 5, and 10-year survival was 97, 93, and 63% respectively after replacement, and 93, 93, and 81% respectively after repair. Finally, a little bit about tricuspid stenosis. Actually, in the 2020 guidelines, there was no mention of tricuspid stenosis, so I got this part from the 2014 guidelines. The stages of severe TS, stage C and D. This is severe TS. The valve anatomy would be thickened, distorted, calcified leaflets. The hemodynamics, the velocity would be more than 190 and an area of less than 1. There is also the hemodynamic consequences of RA and IVC enlargement. And the symptoms might be asymptomatic or variable depending on the severity and the degree of obstruction. So the guidelines regarding tricuspid stenosis, class 1, tricuspid valve surgery recommended for patients with severe TS at the time of operation for left-sided valve disease. Also class 1, tricuspid surgery recommended for patients with isolated symptomatic severe TS. And class 2B, percutaneous balloon tricuspid commissurotomy might be considered in patients with isolated symptomatic severe TS without concurrent TR. Sorry about this picture. So the surgical treatment is through commissurotomy. Again, there was not much detail even in the textbooks about this part. Usually unnecessary to open all 3 commissures because that will likely result in significant tricuspid insufficiency. And surgery is preferred over balloon commissurotomy because most cases of severe TS also have concurrent TR, and the balloon commissurotomy may exacerbate the TR. These are my references, and thank you.
Thank you, Dr. Zahra, for your comprehensive presentation about TR, repair and replacement. And also I would like to thank Dr. Farid for joining us today. And if he has a comment or participation in tricuspid valve indication and surgical techniques. Okay, I think Dr. Farid is away. So,
السلام عليكم. السلام عليكم.
السلام ورحمة الله. أهلا دكتور.
معليش عفوا. First, it's a very nice presentation and overview and summarizing the guidelines. Many times we face the same question clinically. So looking at scenarios, I think will be beneficial for such a presentation. If you do have any scenarios that will help. One of the things that we have to consider, you just mentioned the replacement and the replacement and the different kind of repairs. In cases of endocarditis, especially when you are dealing with IV drug abusers, many people will take the more difficult route, which is basically considering not to operate on those patients. We looked at those some time ago. I'm not sure about the current literature, what does it say, but once a drug abuser develop endocarditis, the likelihood that they will die within the next 1 year is very high. So many people will go with antibiotic treatment for as long as possible, and then after that, either continue with suppressive antibiotic or taking the patient for surgery after a few months. The other thing, as a comment maybe, will be attention to details about the conduction tissue. If you damage the conduction tissue in cases of, in any surgery basically, it shortened the lifespan of the patient by 10 years. So you have to be, in that regard, very careful about dealing with conduction tissue area. And the technique you mentioned about suturing in the leaflet, I think is the best, rather than shallow sutures where the conduction tissue is. What else I wanted to say? Valve in valve is promising. I haven't seen any cases yet in our institute, but it's definitely one thing that we are considering. Also, valve repair through the clip systems, I think is also coming abroad. That's it. Thank you very much. And if you have any questions, I'll be more than happy to help.
Okay, thank you, Dr. Farid. What about the Dr. Zahra mentioned for the bioprosthesis valve and the mechanical valve in the tricuspid position. She mentioned the meta-analysis which reviewing there is no benefit. Also, we know the right side is a low pressure system and highly susceptible for thrombosis. So most of the cases which we saw either repair or with ring or replacement with bioprosthesis. So on what base that meta-analysis discussing no preferability?
The literature review on this topic shows no difference between the complication rate and the mortality rate if you use mechanical valve or tissue valve. But many surgeons are weary about this. In our institute, one of the surgeons, I think it's Dr. Sane, have done quite a few of those right-sided mechanical valves. And he was enthusiastic in the beginning, but in our population, with the type of patients and their compliance with medications, and especially the anticoagulation that's required, it became obvious that that may not be a good choice. We looked at our compliance with Coumadin. 60% of the patients were out of range at the time of the first visit. And that continued through the next follow-up over a year or so, indicating that many of those patients actually have low levels INRs, subjecting them to the risk of thrombus formation and clotting of the valve. So yes, I agree with you. Many surgeons still, and especially in our institute, almost all of us use tissue valve in for the replacement of the tricuspid valve. By the way, the recommendation also for those patients are to continue the patients on warfarin for at least 3 months.
Mm-hmm. Okay. Thank you, Dr. Farid. And I will open the floor for the question from other colleague. Any question, any comment? Please go ahead. Okay.
One comment about the tissue valves. There are two important advances that happen on the tissue valve. One of them is the development of the scaffold, and then using the stem cell to populate those with native tissue. And this is, and some of those experiments on those valves have shown that up to 26 million beat, which is quite a bit, almost like somewhere between 20 and 30 years for an average person. And it can be probably something for the future. Also, the other thing is that the mechanism that's used, which depend on two factors, zero pressure preparations and the use of bisphosphonate as a anti-calcification chemical that's used in the tissue valves. Both of these have made the bovine pericardial valves more durable. Have been, the most recent reports is somewhere around 20 to 25 years.
Okay. Very nice contribution. Thank you, Dr. Farid. Okay then, any question, any more comment, please? go ahead. Otherwise, we will conclude this session and we will take a break by 20 minutes. Then we will start again with the redo with Dr. Ahmed on or at 3 p.m. Thank you. Assalamu alaikum. Welcome back. Now we'll start with Dr. Ahmed for the third session, the last session today, with the reoperative valve surgery. Dr. Ahmed, you can start.
Assalamu alaikum. Good afternoon, everybody. My presentation today is going to be about reoperative valve surgery. My name is Ahmed Al-Amri. I'm a cardiac surgery resident in King Fahd Medical City. Let's start with the objectives. My objectives for this presentation is to give a preoperative consideration in patient for redo valve surgery. We'll talk about the pitfalls, about re-sternotomy. We'll talk about aortic, mitral, and tricuspid valve redo. These reoperations most commonly involve structural deterioration of the bioprosthetic valves, or a progression of the native valve disease, or in terms of mechanical valve, it can happen in the need of reoperation in a patient with thrombosis, valve thrombosis, or infective endocarditis. It's more difficult than the primary operation because of the adhesions around the heart, the presence of more advanced cardiac pathology. As you know, those type of patients considered for redo are having an extent of their functional status and the cardiac dysfunction most of the time. Reoperation of valve surgery considerably has higher risk than the primary valve surgery. So preoperative consideration is the most important aspect before proceeding with the surgery. You have to have an idea about the history, type of previous cardiac surgery, relevant presentation history and comorbidities. Dig in the history about the sternal infection, mainly mediastinitis, that can increase the adhesions, and deep sternal wound infection. Medication that can increase the risk of bleedings, like anticoagulation or antiplatelets. There are multiple risk factors in redo surgery. From the literature, if you look at the factors that increase the risk of adverse events or mortality in patient with redo, starting with the advanced age, the older the patient, the more risk. Impaired ejection fraction, congestive heart failure, advanced preoperative functional status, the timing of surgery in terms of urgency of the operation, the presence of preoperative shock, concomitant cabbage, or the presence of previous bypass grafts, prosthetic valve endocarditis, surgery for paravalvular leak or valve thrombosis or prosthetic dysfunction, renal dysfunction, and COPD. So one of the most important tools to utilize before planning your redo surgery is imaging, and starting with a chest X-ray. Chest X-ray can give you an idea about the proximity of the cardiac chambers and the main vessels to the posterior sternum, and it can help you also counting the wires that you need to remove before going to surgery. But chest X-ray is not enough for planning your redo surgery. Most of the patient needs a CT chest with the contrast. CT chest, more sensitive, more specific in assessing the proximity of the cardiac chambers and the main vessels and the surrounding structure to the sternum, anticipating the risk of injury during re-entry. As you can see in this in the left picture, you can see the how adhesions cause a close proximity of the right ventricle and the ascending aorta to the posterior sternum also can give you an idea about the calcification of the ascending aorta and the place where you have to put your clamp on or cannulate. In patient with the previous venous or arterial graft, previous CABG, it can give you an idea of the proximity of the graft to the sternum. So as you can see in this picture, the Lima graft appear to be in the midline and in close proximity to the posterior upper sternum. All the patients should be examined in terms of angiogram if indicated, and all the patients with previous CABG should undergo angiogram prior to redo surgery to assess the patency of the graft. So the common structures that can be injured during resternotomy are structures that is usually adherent to the posterior sternum, mainly the right ventricle, right atrium, innominate vein, lungs, or venous or arterial graft, and also the ascending aorta. So in planning your resternotomy, you have to prepare your peripheral cannulation sites. And this issue have been not clear which patient need to be peripherally cannulated or which patient should be not cannulated, and what should be the plan in redo surgery. So I've looked at this report in high-risk reoperation stenotomy in the cannulation technique, and they had a nice algorithm to help guide you for the need of peripheral cannulation in those patients. So if you anticipate a cardiac injury based on the CT chest, if there is a high risk of injury, then it's reasonable to go to do your cut down femoral or axillary in terms of arterial and venous to do your venous cannulation, and to go on bypass before opening the chest. If you have moderate risk for injury, then it's reasonable to go to put your bear string in the femoral for both arterial and venous cannula, and keep it ready in case any injury happen during your re-entry. If you have a low risk for injury, then you can put your arterial line, the one usually placed by anesthesia, into the femoral, and put your venous cannula or venous line in the right internal jugular vein, so it can be easily accessible if needed during your re-entry. So if high risk, cannulate and go on bypass before opening the chest. If moderate risk, then prepare for cardiopulmonary bypass. If the low risk, then you just make it easily accessible in case you need it. So before sewing the sternum, you will open the skin subcutaneous tissue and extend your incision usually inferiorly into the epigastric fascia. Open the inferior epigastric fascia and dissect the inferior border of the heart from the chest wall. The sternal reentry itself, we have multiple technique or options for sternal reentry. We have mainly the most agreed on is the three options mentioned here. Some of them are seems to be safer than the other options, and it depends on the risk of injury that you have examined before planning your surgery. So option number one is untwist the wire, but keep it in situ. Then use the oscillating saw to divide the anterior sternal table. Then use a sharp dissection by scissor to divide the posterior table. Option number 2 is take out all sternal wires, then divide the anterior table using a oscillating saw and the posterior table using a sharp dissection. Option number 3 is remove all the wires, then use a oscillating saw to open both anterior and posterior table. What seems to be is the option number 1 is the safest, and option number 3 is usually can be used only in low risk patients or patients without any proximity chambers in close proximity to the sternum. We can also use the sternal retractor. Re-sternotomy retractor helps elevating or lifting the sternum during your re-entry to help you help in exposure and to help in avoiding injury to a near structure. So your dissection is mainly for releasing the pericardium and prepare sites for cannulation, mobilize the heart for exposure of the valve. You usually start with the right sternal release. Stay close as possible to the chest wall to avoid injuring the right atrium, right ventricle. Start from the diaphragm toward the right atrium, then the aorta. For the left sternal release, again, stay close as you can to the chest wall. Be aware of left internal mammary artery if used before for grafting. The space lateral to the aorta and above the PA might need to be exposed for safe aortic clamp. In terms of myocardial protection and redo sternotomy, the best option and the safest option is to go for combination between the antegrade cardioplegia and the retrograde cardioplegia. The antegrade cardioplegia, there is a risk of dissemination of debris if there is a previous cabbage, and it will not be effective in case if arterial graft, Lima graft was used or Rima graft. Retrograde cardioplegia need to clamp the arterial graft and need to monitor continuous monitoring to confirm the uniformity of the cardioplegia, and the best option and the safest option to go for induction by antegrade and maintenance by retrograde cardioplegia. So now I'll talk about a difficult scenario. What can happen during your re-entry? Catastrophic hemorrhage during your re-entry. If you face a hemorrhage during your re-entry, call for help and bring the sternal edges together, usually using towel clamps. Heparinize the patient, cannulate the femoral artery and vein. That's why it's better to be ready with the femoral and femoral artery and vein before opening the sternum. Go on bypass, start cooling the patient, and then as soon as you put your arterial cannula, you can use the pump sucker to return the blood to the bypass. And if you need an extra or the bleeding is increasing, you can also ask your perfusionist to provide you with an extra sucker. Be aware of left ventricular distension during the cooling caused by ventricular fibrillation. So also more complex, increasing the complexity of surgery, the presence of previous cabbage graft. So in this situation, you should avoid manipulation of the vein grafts because this can increase the risk of embolization. If patent Lima graft presence in the midline, then avoid dissection of the lima graft and just cool the patient down to 28 degrees and go on with your redo surgery without dissecting and clamping the lima. So what if you have the situation of injuring a patent lima graft? What is the strategy to restore the flow to the LAD? So these options are not from the best to the least, but starting with the SVG to LAD, then ligate the lima if the injury is severe, SVG to lima stump, SVG to lima, and repair the lima at that time. Lima stump to arterial conduits, lima stump to the aorta, and some surgeons prefer to do primary repair of the lima by using the coronary shunt. So basically, just proximal and distal control to the injury site with the usually bulldog, and insert a coronary shunt into the lima to ensure blood flow to the LAD, and repair your lima primarily, and then remove your coronary shunt. It's more difficult situation, but it can help in some types of injury of the lima graft. There are other options to avoid dissecting the lima graft, the patent lima graft, which was proposed in this paper. They proposed a technique that was used in a small number of patients and proven to be safe and effective. And this technique needs a hybrid OR room where an angiogram is available. So before you put your closed clamp on and give your cardioplegia, you can insert a catheter into the lima graft and balloon inflate the catheter to obstruct the flow of the lima without any need of dissection during your surgery and risk of injuring the patent lima graft. So this technique can be also used as an alternative to dissecting the lima. Although the no dissection technique for the lima have been proven to be safe technique. So not all the times you need to dissect the lima and clamp it in order to clamp it. In this technique, they only went for hyperkalemic cardioplegia or hyperkalemic arrest with moderate hypothermia, and their result was showing safe that this technique is safe for patients with redo with a good outcome. So talking about the aortic valve redo, the options available for patients with aortic valve dysfunction or the prosthetic valve dysfunction is redo sternotomy, which is the most common approach, mini sternotomy, transcatheter valve in valve, or finally aortic bypass. For redo aortic valve through sternotomy, multiple reports and multiple data have shown that the operative mortality of aortic valve redo, especially first redo aortic valve, is shown to be around the mortality being around 4 to 5% in most of the data or the literature. In midterm result of the redo cardiac operation research database, they identified the risk factors or the subgroups that had an increased risk of mortality. So the mortality was ranging in this group between 4% up to 10%. Factor that increased risk of mortality was the age, more than 75, the functional status, and the timing of surgery needing for an urgent or emergent surgery, and the presence of endocarditis. And also the surgical complexity affected the outcome. not in terms of mortality, but in terms of hospital stay and in terms of needing of increased length of ventilatory support or need of transfusion. Complexity of surgery, meaning that not only isolated aortic valve, the need of aortic valve in concomitant with other cardiac surgery. Mini sternotomy can be done with the. This is a video showing the mini sternotomy. So mini sternotomy is done usually through a small incision, upper sternal incision up to the third intercostal space, and after you open your skin and subcutaneous fascia, identify the wires, and then you use your isolating saw with the lifting of the sternum, as you can see, and then you can make an upper mini sternotomy and put your retractors and expose the aortic valve. A cardiopulmonary bypass in this upper mini sternotomy can be done through a central cannulation or peripheral cannulation. And the advantage of this technique is to avoid dissecting the heart from the posterior sternum and avoid the alternate structures injury during sternotomy. In this situation, they use the central arterial cannulation and the femoral venous cannulation. As you can see, you can put your LV vent after you put your cannulation and start on cardiopulmonary bypass, and then you carry on your procedure as conventional aortic valve replacement. The transcatheter valve-in-valve technique is a promising option for alternative for redo sternotomy. It has been examined over the last 15 years, and there was a limitation for transcatheter valve-in-valve. Although the outcome in high-risk and prohibitive risk patient was promising, but there is a limitation for this technique, which has been shown in this study to be the bioprosthetic failed valve size. So the smaller the size of the implanted valve before, the more risk of failure and mortality at 1 year. Also, the type of valve failure. If the valve failure was in terms of valve stenosis, also those type of patients had a worse outcome than the one with valve regurgitation. The more risk, STS score risk, the more risk of failure and mortality. The long-term outcome for transcatheter valve-in-valve also showed the same result in terms of that the size of the failed bioprosthetic valve is important. So the smaller the size, the worse the outcome for the patient with needing a re-implantation of aortic valve. Even the follow-up up to 8 years. And also, as we know, the type of patient who were enrolled in this study, transcatheter valve-in-valve, were the patient who have high risk for surgery or the patient who are older. So that's why the survival was not promising at 8 years, being at 38% only. So it's a good option, alternative for redo sternotomy and mini sternotomy in high-risk patient and prohibitive risk patient, but still, until now, there is a lot of limitation for this technique. Aortic valve bypass, I've never seen it before, but it's mentioned in the book. In inoperable patients who needs an aortic valve replacement, you can give them the option of, and the patient who have an hostile chest, you can give them the option of aortic valve bypass. That's going through the left thoracotomy, reaching the apex of the heart and placing a conduit, valve conduit, from the apex of the heart to the descending aorta, bypassing the aortic valve. And this was this technique was showing good outcome in those type of patients, inoperable high-risk patients. For the mitral and tricuspid valve redo, the options are resternotomy, right thoracotomy, right mini thoracotomy, and in the mitral valve, transcatheter valve and valve also have been started now. So right thoracotomy for mitral valve redo, usually through the anterolateral thoracotomy. It provides an excellent exposure to the mitral valve. It's not only for the redo cases, also for the primary mitral valve surgery. Some physician or some surgeons will like to do peripheral cannulation for those type of patients, but also the central cannulation can be also done. But peripheral cannulation can help in better exposure of the valve, decreasing the crowdedness of the field, of the operative field. Right mini thoracotomy. This study shows that that the minimally invasive approach, video-assisted, right video-assisted thoracotomy showed was associated with lower 30 days mortality and significant lower blood loss, and provided an excellent exposure of the mitral valve in cases of redo mitral valve and the patient who have high risk for resternotomy. For the mitral valve and the mitral valve in ring, redo mitral valve, it has been studied, or have been studied over the last few years, and this is systemic review comparing the mitral valve and the mitral valve and ring. The mortality, as I mentioned before, for all most of the valve redo was around 5 to 10% or 5 to 15%, and the mortality rate for the mitral valve and in high risk for surgery patients was showing a similar result, from 30 days mortality being between 0 to 10, and for the 1 year outcome was reaching up to from 10 to 18%. For the mitral ring and mitral valve and ring patients, they showed a good 30 days outcome, but at 1 year, the mortality rate was not acceptable, reaching 30 to 40% mortality rate for some of the studies. For the tricuspid valve redo, I brought only this paper, which is a paper was published recently, 2021, from a group in King Faisal Specialized Hospital in Riyadh. They published a paper about the isolated reoperative tricuspid valve surgery outcome and risk assessment. So they had a retrospective analysis of 170 patients who underwent isolated redo for tricuspid valve surgery, and the outcome was comparable and even better than some of the literature, being at 30 days around 11% and more than 30 days also around 30%. Survival was evaluated up to 20 years, being an 80% survival. So they concluded that reoperation for isolated tricuspid valve that after failed a previous valve surgery is safe and had a favorable mortality and good survival. So take-home message, consider reoperation before decline in functional status because it's an important risk factor. Assess the RV aortic proximity to the sternum preoperatively with CT scan. Consider an alternative approach, especially with patent bypass graft. Example, right tricuspid for MVR or mini sternotomy for AVR. Consider alternative cannulation technique to gain safe entry. Address the Lima LAD graft if present, and the saying is dissect it out and clamp it, or cool and ignore it. Use the no-touch technique for bypass graft. Use conservative myocardial protection strategy, antegrade and retrograde, systemic cooling, warm induction, and final dose hot shot. If using a hypothermic fibrillatory arrest, be aware of LV distension or obscuring the operative field. Place an external defibrillator pads and consider the use of anti-fibrinolytic therapy or agents to decrease the risk of bleeding. Thank you for listening, and please, if you have any questions.
Thank you, Ahmed, for your comprehensive presentation about redo. Just I have one noticed for the CT pre-op, as in King Faisal Specialist Hospital, they are doing most of the cases usually redos, and they are most of the surgeons they are doing it without even CT. So one of them with us, Dr. Farid, if he has a comment on that while exiting the redo sternotomy.
Well, a very nice review, by the way. It reminded me of a nice presentation I thought I did many years back. I gave a grand round about how to do a redo, and that was in 91. Anyway, thank you very much for the presentation. Regarding the CT scan, use of the CT scan, in our practice, mainly because of the huge experience and the huge number of patients are redos, it's not that feasible to do CT scan. We do order it for some cases, but we rarely do so. And we think we can manage, and we have actually managed very well with those. It doesn't mean that we don't have our share of reentry injury, and you just have to know how to manage those patients with quick access and going on bypass as soon as you can. My advice to the junior surgeons who are just going out for practice is that it's okay to order it in your first few cases just to feel safe, and make sure that you have an access to the femoral artery and vein, at least with the catheter, so you can use the percutaneous if you have to. And then after you gain that experience, you can give up this routine practice into selective practice. That's my advice. Thank you.
Okay, thank you, Dr. Farid. Any comment from the group or questions? Then thank you, everybody, and thank you, Ahmed, again, and we will conclude today. See you next week.